Şu anda çeviriyor kendisine.
Tamam, oldu.
Duyabiliyor. Sıradaki konuşmacımız İngiltere Southampton Üniversitesi'nde kıdemli perinatal psikiyatrist ve onursal kıdemli öğretim üyesi olan Dr. Alain Gregoire. Kendisi aynı zamanda Üsküdar Üniversitesi Fahri Doktoru. Sayın Gregoire aslında uzmanlık eğitimine kadın hastalıkları ve doğum alanında başlamış. Ancak gebelik ve doğumla ilişkili ruhsal hastalığı olan kadınların çok hasta olmalarına rağmen en az bakım alan kadınlar olduğunu fark etmiş ve bu konuda bir şeyler yapmaya karar vererek psikiyatri eğitimine geçiş yapmıştır. Ve yaklaşık 30 yıldır perinatal psikiyatri alanında çalışmalar yapmaktadır. Sayın Gregoire'ın konuşmaları Türkçe'ye çevriliyor olacak. Konuşmayı Türkçe dinleyebilmek için alt panelde bazı ikonlar var. Interpretation yazıyor olması lazım. Dünya şeklinde bir ikon. Sizlerden ona tıklayıp ardından Türkçe kanala geçmenizi rica ediyoruz. Aynı ikona tıkladığınızda bir de Mute Original Audio yazısını göreceksiniz. Bu seçeneğe de tıklarsanız yalnızca tercümanımızın sesini duyarak konuşmayı rahatlıkla dinleyebilirsiniz. Şimdi izninizle deneyimlerinden ve bilgilerinden faydalanmanın heyecanı içinde Anne Ruh Sağlığı için Birlikte Çalışmak başlıklı konuşmasını yapmak üzere kendisini yayına davet ediyorum.
Well, thank you very much indeed. It's a huge pleasure to, in a way, be in Üsküdar again and in Istanbul again. My last visit was absolutely wonderful. I had an extremely warm welcome from everybody and was hugely honored to receive this honorary doctorate from Üsküdar University, a very great university, and to meet with so many fantastic people working in this field. So a huge pleasure to be with you again, and I hope to be contributing a little bit to today's magnificent conference, presenting a little bit of the international research and science in the area of perinatal mental health, and a little bit of the work that is going on internationally to try and promote better care for women and babies and families in relation to their mental health around maternity. So the title I am speaking to is Working Together, and it is very important in perinatal mental health that we work together with people from many different areas of professional work, from maternity services, from public health services, from mental health services, and increasingly internationally, people working as specialists in perinatal mental health, so mental health during pregnancy and the first 1 or 2 years postnatally, who specialize in not only the mental health of the mother, but the relationship of the mother with the baby and the development of the baby and the wider, the effects on the wider family, because all of these things are important. Mother's physical health, mental health, her role as and her functioning as a mother, and her functioning in relation to the family and the support that in return the family give her and wider society gives her. All of these are critical, as I hope you will see. But in the current context that we are all facing at the moment, which is in a way at the moment number one in the thinking of everybody, is the Covid pandemic. And I just wish to put to you that perinatal mental health has been a hidden pandemic for centuries. And it is only recently that the science and indeed political and professional thinking has started to understand the scale and the impact of perinatal mental health problems on our populations. And so I would like you to keep in mind that we are talking about something that has a huge pandemic effect on populations across the world. And how is this so? How can I speak in these extreme terms? Well, let us think for a moment at how common just one mental health complication of maternity is. Let's just think about depression. Depression at the most conservative, at the absolute minimum estimate of prevalence is between 10 and 15% of any population measured across the world. And I will show you a bit later that the figures in Turkey are indeed much higher than this. And this is a far higher risk level than any of the serious physical health conditions that we invest, quite rightly, a great deal of money in treating in physical health care for maternity. And most countries around the world, including very low-income countries, are investing in maternity care, in the physical aspects of maternity care, because at last we have understood how important this is to whole populations. But we are only just beginning to realize that investment is equally required in mental health aspects of maternity care. And this is only just beginning to happen in nations around the world, but not just in high-income countries. It is also, as I will show you, starting to happen in low and middle-income countries as well, because it is now acknowledged by the World Health Organization, the World Bank, and by governments around the world that economically, as well as in terms of the health of the population, this investment is crucially important. If you doubt that depression belongs in this list of what are accepted as being serious health complications of maternity, let us just think for a moment about what impact depression has on women of childbearing age. And you can see here the WHO Burdens of Disease study, which looks for women of childbearing age at the impact in the pale blue in low and middle income countries, the top impacting health conditions known to humans. And you will see that depressive disorders are the most burdensome in terms of life years lost through premature death, and life years lost through morbidity or disability, are more burdensome than HIV/AIDS, more burdensome than maternal sepsis, for example, and indeed more burdensome than any condition that we know of. So depression is a very serious condition when you look at it in terms of the impact on human lives, on the population, on morbidity, and on death. So it absolutely belongs in that list of very serious conditions. It is just that those other physical health conditions we accept as serious because they are dramatic, because they are theatrical, because they are very acute. And we ignore the more chronic, yet much more, in many ways, much more serious conditions that happen in mental health. And we must stop doing this. We must be more sophisticated, and we must listen to the science rather than just thinking about what we see in front of our eyes and what gets us excited. We get very excited by blue masks and surgical gowns and machines that go beep and blood on the floor. But actually, if we are serious about health, we need to think carefully about the data. Not only are common conditions like depression the most common health conditions in maternity, but we also know that the most serious mental health conditions are more common at this time than at any other time in human lives. So the increase in risk in psychosis immediately postnatally is higher than you ever see in any humans at any time in their lives, male or female. And in fact, of course, it only happens in women. And not only this, but postpartum psychosis is known to be the most severe of all the psychoses we see. So it's most common of all the psychoses, but it's also most rapid onset, most high risk, and most acutely severe. But there is also good news. It is one of the most easily treatable psychoses if you catch it early, and it is the only psychosis that we can predict the date when it is going to happen, and we can actually do things that can help to prevent it. We don't yet have 100% prevention strategies, but we absolutely do have things that in individual women we can see help to stop psychoses happening. And as an explanation for this very high rate of psychosis, one of the main causes of this is relapse of bipolar disorder or first episodes of bipolar disorder. And in this data from Boston, you can see that women who are known to have bipolar disorder at the beginning of pregnancy and stop their medication. In this particular study, it was stopping lithium, but it applies to stopping any medication for bipolar disorder at the beginning of pregnancy. You see that about 50% of women relapse during the course of the pregnancy, but this is about the same as women who stop who are not pregnant. If they stop medication, about 50% will relapse in about a year. So you can see that line is the same. The difference is that more women stop at the beginning of pregnancy. So we need to get in early in pregnancy to identify women with bipolar disorder and help them make decisions about preventing their illness, help them choose whether to go on, to stay on or go on different medications, and help them to choose medications if they are deciding to try to prevent becoming ill. The yellow line shows when the baby is born in women who are pregnant. Obviously, women who are not pregnant in this study didn't have a baby then. You can see that they continue, the blue curve continues as you would expect on any so-called statistical survival curve. But the pregnant women of those who were still well, 70% relapsed postnatally. So there is a big difference in the perinatal period, a huge increase in risk. And in fact, we know that giving birth is the most powerful trigger for bipolar episodes that we know of in humans. So you take all of this together and you can see that the perinatal period is a critically important period for mental health, but also for overall maternity health care. Now, of course, the really important thing going on here is that we're not just talking about the health of one person and the well-being and the future of one person. We are also talking about the future and the well-being and health of the baby, the fetus, and the baby in the very early years of life. And increasingly, as I'm trying to illustrate in this picture, increasingly the research is shouting loudly the situation of the fetus and of the baby. And here is one example of a UK study, of which there are now, since this was published in 2003, there are now multiple studies all over the world showing exactly the same thing. So I'm just going to pick a couple of research findings to illustrate what all the research all over the world is showing. And that is that there is an impact of maternal mental health problems in pregnancy. The most studied are the most common ones, anxiety and depression. And you will see from this study that there is a doubling, 2 times the risk of emotional and behavioral problems in the child. And this is data from 7 years old, but we now have prospective data, so followed up from pregnancy right the way through to those children becoming adults in their 20s, still showing a doubling of risk of emotional and behavioral problems. In adults, we would call them mental health problems or mental illnesses, increasing. As a result, even if you take into account all the other factors that we know predict mental health problems, still showing an effect of increased risk from having mother being unwell mentally in the pregnancy. And here you can see how this data pans out. You can see the 7-year data that I just showed showed you, but it continues. This is data up until 13, and just recently published is data up until their 20s from some of those earlier studies. So we are seeing this emerging very consistently as a story. And what we also know, of course, and I haven't got time to go into this, but those of you who are familiar with the concept of ACEs, adverse childhood experiences, will know that early disadvantage is the most damaging type of disadvantage with the strongest continuity. And this forms part of that story. Maternal mental health problems are very high up amongst the ACEs. And here is an example from another study that followed prospectively, so from pregnancy onwards, followed up mothers and their babies. And what they found when they looked at the children who were depressed at the age of 16 is that all of the children who were depressed at 16 in this study had mothers who had been depressed themselves. None of those children who were depressed at 16 had had mothers who were completely well, and particularly the effect was strongest for maternal depression during the pregnancy. Now, very, very important to remember, this is not saying that all children of mothers who are depressed will become depressed, okay? This study shows that all children who are depressed had mothers who are depressed. Most children of mothers who are depressed are okay. Okay, really important. So if you take all mothers who are depressed, most of the children are fine. But if you take children who are depressed, all of them in this study had mothers who were depressed. Okay, really important point, because we don't want to add more anxiety and a greater burden of guilt onto parents. Firstly, it is not mother's fault that she's anxious or depressed. And secondly, most of the children are fine, but there is an increased risk. And when I speak to mothers themselves, I explain that you are all the time dealing with risk. You know, you want your children to go to school because that is very good for their development, but you know that there are risks at school. They might be bullied, they might be badly treated, they might be hit by a bus on the road to school. There are risks everywhere, but you don't keep them locked in their bedroom for the rest of their childhood because you don't want them to be hit by a bus. You manage the risk as best you can. And the whole of parenting is about feeling guilty about making the wrong choices. I'm a parent of 3 children. I know, I think back and I say, oh, did I do the right thing? Oh, no. And there are always risks for children. So this is important to explain to parents. This is not their fault. We do the best we can. We want the best. But for us professionals, it is critically important, and indeed for politicians, it is critically important to know this science and to say, if we want to prevent problems for children, if we are serious about this, and for the next generation of adults, we need to start now to care better and to support better women and their mental health in pregnancy and postnatally. That is the critical time when we can prevent problems for children, health problems, development problems, schooling problems for children, and health, physical and mental health problems for adults in the next generation. And we know that we can do things. So this is a beautiful study that looked at cortisol cortisol levels, and cortisol levels relate to anxiety. So for cortisol, for increased cortisol, read this as increased anxiety. And what you see is in the graph with the sloping down on the left, you can see the development of the child on the Bayley Development Index, and the higher the cortisol level in the mother, so the higher the anxiety in the mother during pregnancy, you can see going along the bottom line, the higher the anxiety, the worse the development score, okay? So low cortisol, low anxiety, a good high development score, high cortisol, high anxiety, and the child, after it is born, at the age of 2, in fact, has a a poor postnatally. So if you help the mother, or the mother manages to develop a secure attachment relationship, then what you can see is that there is no effect of antenatal anxiety on the development of the child. That slope disappears, which means that if you act, if you do things early, we can reverse the effects that we see of anxiety and depression. But this only happens if you act, and if you act early. If you do nothing, then there will be children who are affected, and there will be more children who are affected. And of course, there will most likely, because anxiety and depression problems, for example, are recurrent problems, are long-term problems in health for the mother, there will be longer morbidity and, of course, a higher risk of mortality as well. We've looked a little bit at the global findings in relation to maternal mental health and child development. Does this apply just as much in low and middle income countries as in high income countries? So quite a lot of the research I showed you was from high income countries, not all of it. But does this apply in low and middle income countries as well? And the answer is absolutely yes. In fact, the same messages are probably even stronger for low and middle income countries. So if you take, for example, just the very crude measure of growth in children, what we see in studies in low and middle income countries across the world, consistent findings from the research, is that if you just measure physical growth, there is an effect of maternal depression that is very substantial. So in these studies, a third of the risk of low growth could be attributed to maternal depression. You think, well, how is this possible? But if you think about it, actually, it is obvious. If you are poor, if resources are limited, you need your parents to fight for and work for getting what little food, what little resources, what little wealth there is available. And if your parents aren't functioning properly, and in order to work, in order to get food, in order to feed you, in order to nurture you as a baby, you need your parents' mental functioning to be as good as it can be. It is really hard living in poverty. And it is your mental health that you need more than anything in order to survive and in order to thrive. So when you think about it in this way, it is obvious that if mothers are depressed, this is going to have a profound effect on the development of the child. And this is exactly what the science shows us. What can we do about it? Well, we know that we can do quite a lot in terms of changing this. But let me just remind you that this childhood adversity has an effect on the adult, but that adult will at some point very likely become a parent. And that childhood adversity that that baby faces, that affects them as an adult, when they become a parent, that shows as well. So what is the highest risk factor that we know of for perinatal depression? It is when we have suffered emotional traumas as a child. So now you can see that there is a cycle where the child suffers as a result of mental health problems or other ACEs, becomes an adult who becomes a parent, who then suffers with their mental health. That is an ACE, that is a risk factor for the child. The child grows up to become an adult who becomes a parent, who is more likely to suffer from mental health problems. So you have not just one generation, but two generations, and the next generation, and the next generation. So we have a potential here to prevent terrible things happening for mothers now, for children now, for those children when they become adults, for their children, for their children's children. This is the most fantastic opportunity that science is now giving us, that no generation has never ever understood before, that science is now giving us to do something to change health in this population and future populations for our nations. And this is why countries all over the world are beginning to understand that if we invest now, the returns can be fantastic. And we know that this impact crosses the generations. So here is a study that looked at the effect of the mother's adverse childhood experiences, of mother's childhood maltreatment on their children. So not on the mother later on, but on the mother's children, and found a strong dose-related effect. So the worse that the mother's childhood experiences, the worse her children's risk of having difficulties. So here is the model that you can see that is really important to understand, that there's an interplay between adverse childhood experiences, maternal mental health, and effects on the next generation. And what we need to do is intervene anywhere we can in that cycle. And one of the ways that we know we can intervene is in maternal mental health in the perinatal period, in the early years. And we know about things that we can do to affect this. So here, for example, is research that tells us about how some really useful information about predicting and preventing psychosis. So looking at the severe end. And for example, in this very nice study, you can see in the top left-hand corner that women who are known to have bipolar disorder have risks of becoming ill, of relapsing throughout the pregnancy and particularly postnatally, but throughout the pregnancy. Very similar to that study from Boston that I showed you earlier on. But women who only ever have had in the past postpartum psychosis, who have never had bipolar episodes at other times, don't seem to be at risk in pregnancy, but do seem to be at high risk postnatally. So this is helpful for professionals, for clinicians, in advising women and in treating women and in predicting and preventing very serious illnesses. If you look at the right-hand side of the screen, the gray slide, this tells us about the triggers of sleep deprivation. And you can see that for postpartum psychosis, PP, sleep deprivation is a particularly powerful trigger. This is useful information because we can do things to working with our colleagues in maternity services, between mental health and maternity, working with women and their families. We can try to do everything possible to help the woman in the perinatal period to get as much sleep as possible, particularly in the postnatal period. And if we work together, this alone can help prevent serious psychotic illnesses. And then in the bottom left, here's a study that looks at whether childhood adverse experiences affected postpartum psychosis. And what you can see is that the risk of postpartum psychosis doesn't seem to be particularly affected statistically by childhood adverse experiences, but the risk of depression is statistically affected. So depression, anxiety, as we know, very closely linked to trauma, but psychotic illnesses don't seem to be so strongly linked to trauma. What do we also know about when depression starts? Well, here's a study that tells us that within the perinatal period, the most common time for depression to start is during the pregnancy. And in this particular study, a third of women in this sample of women who were a normal community sample in a quite poor area a third of them developed depression during the pregnancy, and another 1/6 of that sample developed depression in the first year postnatally. And then in the next 15 years of the child's life, another 6 developed depression. So, and then a third of this sample never developed depression in 16 years. So you can see, the rates of depression in mothers is very high, and this has been confirmed by subsequent studies, and I'll mention that a little bit later, particularly in poor populations, but the time when this is most likely to start is in pregnancy. And what a wonderful opportunity, because most countries, even poor countries, have systems of healthcare in pregnancy, very devoted to physical healthcare, but it is not difficult to increase training, to increase resources and time to ensure that those contacts during pregnancy, physical health, start to also deal, recognize, and help with mental health. And we are now doing this, even in rich countries, we are doing this very badly. So this study looked at the research, found all the women who are depressed, that's the first column, and looked at how many of those women were recognized as being depressed by healthcare professionals and services, and found that most women who are depressed postnatally in this particular study, most women who are depressed are not recognized as being depressed. And of those who are recognized, only about half get any help. And of those who get help, only about half of the ones who get help get good quality help. So the total population who get adequate quality treatment is around 1 in 10 of the women who are depressed. This is scandalous, scandalous. If this was cardiology, the healthcare system would be shut down and the Minister of Health would have to resign. But because it's mental health, somehow we get away with this. Well, no longer. People are starting to say all over the world, this is not acceptable. We have to do better. It's not easy to do better because there are all sorts of problems. Picking up cardiology problems is actually easy compared to picking up mental health problems, because we also have to fight against stigma, which gets in the way of recognizing depression. People are ashamed of talking about their mental health problems. Professionals, particularly in physical health, who are not trained in mental health, are frightened of talking about mental health problems, and so they don't ask. And we have recently seen a study in the UK that asked about why women, so most women, more than 50% of women said they didn't like talking about mental health problems, didn't want to talk to their midwife about mental health problems. And this study asked why. And you can see there are lots of reasons that we broadly call stigma about mental health problems that impact on women's ability to talk about their problems. So that's one of the challenges, but another challenge is that professionals are simply not asking and not doing this sort of work, and we are not, as government and as healthcare systems, seeing it as important enough. And this kills women. So we know that, for example, in the UK, where we probably have some of the best maternal death scrutiny and data collection, we know that mental health is the biggest killer of women in maternity. And actually, where countries are starting to look at this in detail, and you have to look for women who die from suicide because they are invisible. They don't die in the maternity hospital, they die later. So if you go looking for that data, countries all over the world are finding that this is a big killer of women. And in the UK, where we do very detailed analysis of these women's health records and these women's histories, what we find is that 80% of these maternal deaths were seen as potentially preventable if people had taken action to help these women to recognize their problems and to treat them effectively. 80% of them were preventable. Just like we know that physical health problems, physical deaths from physical causes in maternity are preventable to a very great extent in rich countries, in middle-income countries, and in poor countries. And quite rightly, we invest in trying to prevent these deaths, but we are still not doing it for one of the biggest causes of death, which is mental health. So what happens if we do nothing? Well, in the UK, we have calculated the cost to the nation of not acting on maternal mental health, or not doing more, because we do, you know, everybody tries to do a bit, but if we stay as we are, if we do nothing more to help women at this time, it has been calculated by the London School of Economics that it costs us 8.1 billion pounds every year. This is incredible amounts of money. This is as much as Brexit is costing the UK. This is, you know, a big proportion of our health budget. And if we take action, if we do all of the things that our national guidelines recommend, it only costs us £337 million a year, which sounds like a lot of money, but actually in healthcare terms, this is a tiny amount of money. And this is to do everything that needs to be done in maternity services, in mental health services, having experts all over the country. And we know that this can prevent, and economically as well, we have shown that this can prevent, in that of these costs, 3/4 of the costs relate to the costs that relate to the health impacts and developmental impacts on the child. This is a minimum estimate. So in fact, the London School of Economics only looked at the costs associated with scientifically proven effects of maternal mental health, perinatal mental health problems. In only 3 conditions: in antenatal anxiety, postnatal depression, and postpartum psychosis. Most mental health conditions were not included. So antenatal depression, postnatal anxiety, PTSD, psychosis at other times, OCD, all of those were left out of the calculation. So these costs are absolutely minimum. They are in fact much bigger. And we know, we have known for a long time from Heckman's work in economics that the earlier we invest in population well-being, the greater the returns. So if you start working really early, pre-birth and post-birth, investing in whatever sort of program you're doing that's going to make a difference to child development, because of the scaffolding of the way the brain develops very early, you set up neural pathways that can then build neural pathways that can then build neural pathways for healthy, optimum development. So getting in early is critically important. And again, this is acknowledged both in terms of health, in terms of public health, in terms of education, and in terms of economics worldwide, high, middle, and low-income countries. And of course now, not surprisingly, given all this science, there is tons of global policy and guidance from World Bank, from World Health Organizations, from organizations everywhere saying that we must act, that this is really important, that this matters, that we must take this seriously. And because we are talking about long-term problems, the quicker we act, the quicker we start to see results. And the results that we see are not just long-term. So this is not investing for returns that will only happen in 20 years. We can see results very quickly as well as long-term. So there is no excuse to say, for politicians to say, oh, well, you know, this doesn't concern me, or I don't work on this level, I only work on a 3-year level. Politicians need to take this seriously for now, for this generation, but also for generations to come. And what greater achievements could there be for any professional or indeed any politician or any national leader than to be able to improve the well-being and health and happiness of their population, not for years to come, not for decades to come, but for centuries to come. How great a leader would that be? And we know we can do things. So here are studies from low and middle income countries, lots of studies, all showing the same thing, with tens of thousands of participants put together, showing very clearly that actually quite cheap interventions, but interventions that are focused, delivered by trained people, but not hugely expensive, just well organized, can make a big difference to depression and anxiety in women in populations at this critical time in their lives. So I've just realized actually that this is going out on YouTube. That video is confidential, so that will need to be removed if any recording is being left. So if I could just ask you to do that and respect that confidentiality. Okay, so you saw, I'm sure, from that video that you can achieve great things by effective, good quality care, both for the mother, but also for the baby. And that may not look like a big change to people who are not used to working with mothers and babies, but if you are experienced in working with mothers and babies and you know about the science I've been telling you about long-term development, you will understand on seeing that video that if that mother and baby interaction that we saw in the first half had been left like that for any period of time, that could have a significant impact on the development of the child, because we know from studies done as early as the 1980s by Ed Tronick in the States that babies who are starting to switch off, as that baby was, from interaction with a depressed mother, also start to switch off from interactions with non-depressed people around them, and start to switch off generally from interactions with society. And of course, how do children learn? It is by interacting with other human beings. This is not just true of children in schools, this is true from birth. In fact, we know from before birth now, but it is certainly true from birth. And this is the earlier this is, when the brain is developing fastest, the more critical this is for forming and shaping the functioning of the brain and the mind. So completely changing by a small action now, completely changing the trajectory for that baby, who, assuming that good interaction and the mother's health continues to be cared for well, this baby will do very well. Left as it was, this baby would have done really not very well at all, in many, many different ways. We also know that as well as professional care, there is a huge public health requirement and social health requirement to ensure the mental health of women at this time. And this has been shown very beautifully in a study led by Jane Fisher, who's professor in Melbourne, who looked at the impact of changes in public policy and law in Vietnam. And one of the things that she found was that there was a huge impact of a variety of social and policy factors, but one of the most important ones that had a huge impact on rates of depression was the outlawing of domestic violence in Vietnam. And what she found is that once it became against the law for partners for domestic violence between partners, the rates of depression in mothers reduce very considerably. And this actually is not surprising, because we know that one of the biggest risk factors, both for mother's depression, but also for child development, is violence, both mental and physical and sexual violence towards female partners by male partners and fathers. Has a huge impact on mothers' well-being, but also on the development of their children. And if more men were told that you affect the mental well-being, the school achievement of your children through domestic violence, then I think they would start to understand that this has got to change. The rates of domestic violence, I don't know what the studies are in Turkey, but the rates of domestic violence during pregnancy and postnatally in the UK are 20%. 1 in 5 women report domestic violence in their relationships during pregnancy and postnatally. Now that we know that this impacts on their mental health and on the development of the child, this has become a big public policy issue. And this message really needs to be sent out across the world. And this evidence from Jane Fisher shows that if we change that, and it is not difficult to do, it does not cost anything to change the law. It may be politically difficult. Why it would be politically difficult seems a bit mad in a way, but we have to acknowledge that it may be politically difficult to tell men that they should not be violent towards their partners, but it is free. It is an easy thing to do, and it can have a profound impact on the well-being of the population. So these are things that are being looked at all over the world very seriously now. Do and that we know that we should do. So we need to detect problems and we need to deliver care in primary care, in maternity. Very important that we do this. You know, this is not the job of just of mental health care services. This must be done. We have evidence that it must be done in primary care, it must be done in maternity, and it must be done in what we call universal children's services. So whatever services you have that have contact with young families and young children after birth to help with their development. We must do prediction, so we know who is more at risk amongst the mothers and amongst the children. We must do prevention to try and stop it happening at all, but we must also do this detection and treatment. All staff involved must be trained. So those who are used to only doing physical health care, like midwives, for example, need training to understand mental health and mental health care, because they have a job that only they can do. Only midwives are in contact with all women. So they must be able to do that job, and they cannot do it without training. And incidentally, they cannot do it without a bit more time. And then services need to work together. If the midwives are not supported by some sort of backup with slightly more expert mental health care, they can't do the job that they need to do in mental health. And then we need some specialist care at some level. Whether it be in high income or middle or low income countries, you need somewhere some people who really know what they're talking about here, so that they can at least, even if they are not delivering care to every woman in the country, because there are too few of them, they at least can be providing information, guidance on a population level, so websites, and providing information and guidance possibly at an individual professional level, so somebody who a midwife can phone up and ask for advice for. So this somehow needs to be paid for in some sort of central way. And this has been a great change in the UK recently. We now have specialists in every part of the country, whereas only 5 years ago, only 20% of the country had specialists. So now midwives everywhere can phone up and speak to a specialist and say, I don't know what to do, or I'm worried about this woman, is she at risk, or what medication should she have? And there are lots of websites now giving information to women, to other professionals. And then we also, as I've said, need national political action on stigma, on understanding these difficulties, and policy action on things like very big risk factors like domestic violence. Now, across the world, we have 196 countries. We have a huge challenge of 131 million births worldwide. And you know, the pandemic has taught us that the world is one village, one town. We are all one population of humans, and we need to take account of the needs of women all over the world and think about that. Of course, we must do our bit with the woman who sits in front of us, the family who we have contact with, our neighbors, our daughters, children, but we also need to think about the population in our town, in our country, in neighboring countries, because these problems become social problems that will one day impact on us worldwide, just like the pandemic. And there are 13 million women right now as I am speaking to you, 13 million women with perinatal depression. And 90% of those women with perinatal depression are living in low and middle income countries. And we have never even counted the millions of women, even more than with depression, who have post-traumatic stress disorder and what is known as complex post-traumatic stress disorder, the PTSD that comes from childhood traumatic experiences. A new category in ICD-11, critically important, more common than straight PTSD. This complex PTSD, and in fact, the biggest chunk, the biggest element, the biggest diagnostic category of work in perinatal mental health. So here is a map that shows postnatal depression prevalence across the world from lots of different studies, where studies have been done. And this leaves out the high-income countries. So this is focusing on low and middle-income countries. And you will see studies in Turkey, for example, have shown rates of postnatal depression. This is only postnatal depression of over 20%. And remember, antenatal depression is at least as common, and in many studies more common than depression postnatally. And I showed you graphs about how common depression is antenatally. And there is every reason to think it is the same for Turkish populations as every other population of women. So your rates of these so-called common mental health problems are huge and are not really sufficiently acknowledged as being huge and as being an enormous public, mental and physical health challenge for this generation and the next. And of course, you in Turkey are facing the vast numbers of women, of populations that are forcibly displaced as a result of all sorts of human-created tragedies. And we know that amongst populations forcibly displaced, the majority are women with young children. So think now, with this science that I have been talking about, what we are doing to these populations. And do not think that these neighboring populations can't affect us. You know, we are not living in Trump America. We are living in countries with borders that people can cross, and they bring with them their historical traumas. And we have to bear some responsibility for what is happening to people who are suffering all over the world, because we are partly responsible in this international world for this international suffering. And we will see the effects on us, on our populations. And remember, you know, the effects on boys of maternal mental health problems as they develop are on emotional and behavioral problems. And the continuity in boys is into violence and into criminal activities. and into impulsive behavior. Well, what is it that we see in our populations of refugees? We see exactly that. And these are preventable problems. So we have a responsibility. The Global Alliance for Maternal Mental Health, which I launched in 2016, is growing all the time with more and more alliances, continental, international, and national alliances joining. And it would be a great pleasure if your newly formed Turkish alliance were to join. We would be very happy to welcome you. We have new alliances forming all over the world now to try to act and get action. And the national steps to getting action in a country from politicians, from professionals, from services is firstly to get together as an alliance, to agree what you want to see happen, to what you want to see change for the sake of women, of babies and of families of this generation and for the next generation, to develop ways of working that can show that things can be done in your country, and to demand change, to demand it in an ambitious but helpful and productive way. And if there are lessons that we should learn from COVID, well, that is, listen to the science and the experts. Don't ignore the science and the experts, because you do so, you are in danger if you do so. And act on the science. Don't just listen, but take action. And we have also learned from COVID, and this has been a very painful lesson in the UK for our government, invest in preventing in the community rather than waiting to do things that are really expensive. So our government at a very early stage invested in more big hospitals, huge hospitals with hundreds of ventilators and expensive ITU staff, which we've almost never used, and didn't invest in prevention in the community, so-called tracking and tracing people, doing public health work. And the lesson is, don't invest in high-tech machinery until you've invested in prevention. And this applies to perinatal as well. And we've also learned all over the world from COVID that not only is our physical health affected by terrible traumatic experiences for populations, but our mental health as well. And when it comes to economics, it's the fact that people aren't able to return to work, that people are traumatized for years to come, that is going to cost us a fortune in terms of COVID. So these are important lessons from COVID, but they apply equally to the hidden pandemic of perinatal mental health. So I would urge you, take action, but take action understanding what you need to do first. So have a vision, then take action, and action with vision will truly change Turkey, and it will change the world, as Nelson Mandela has said. So I will stop there, and I think we have a few minutes for a few questions. Thank you very much.
Evet, kendisine çok teşekkür ediyoruz. Bazı sorularımız var, onları iletmek istiyoruz. Chat bölümünden bir annemizden soru gelmiş. Anne karnında depresyon ve anksiyeteye maruz kalan bebek, anne 3 hafta içerisinde doğru tedaviye başladıysa ve sonrasında da annenin hastalığını doğum sonrası mümkün mertebe hissetmediyse, anne ilgili, sevgi dolu ise, geleceğinde yalnızca anne karnında 3 hafta yoğun kaygı ve depresyona maruz kaldı diye aynı şeyleri yaşar veya sorun yaşar mı? Yani bir süre sonra, birkaç hafta kadar tedaviye ulaşmış annelerin de hiç tedavi görmemiş annelerin bebekleri gibi geleceklerinde sorun yaşıyor ya da gelişimsel sıkıntılar var ya da yaşayabilir diyebilir miyiz?
This is a very good question, and thank you for answering. And the answer is very, very clear from all the research that the added risk for babies exposed to maternal anxiety or depression in pregnancy or postnatally, the effects on the baby are not inevitable. Okay, most babies are fine, firstly, and secondly, very important, these effects are not irreversible. So they can be reversed Absolutely. So if the mother recovers well, particularly if it hasn't been for too long, and certainly 3 weeks is very short, I would say, in terms of effects on the baby. If the mother recovers well, it hasn't been too long, and the relationship between the mother and the baby recovers, the baby is very likely to be absolutely fine. And certainly there is no reason to think that the baby would have any extra risk compared to any other baby. So this is really, really important to tell mothers. Not irreversible and not inevitable effects. But at a population level, these effects are still there. So for professionals, for politicians, we need to understand that this is important. But for most mothers, things are fine.
Teşekkür ediyoruz. Bir sorumuz daha var. Doğum sonraki süreç anne için bir depresyon dönemi yerine bir travma dönemi olduğunu düşünebilir miyiz? Depresyon durumu ise bu dönemde eş desteğinin yardımı konusunda ne düşünüyorsunuz? Travma için daha farklı yaklaşımlar gerekebilir mi?
Okay. Yes. So thank you. That's also a very important question. So there has been recently much more research into traumatic experiences around the birth itself and traumatic experiences of other types in pregnancy and postnatally. One of the important lessons that comes out of research into trauma is you are much more vulnerable to the effects of trauma. So trauma affects you much more if you had early trauma in your life. So if you had early childhood traumas, then you're much more likely to be affected by later traumas when you're an adult. It reawakens things. So that's the first really important thing to point out. So for us professionals, if we ask about what was your childhood like, you are now pregnant, tell us a bit about what your experience of being a child or a baby, even if you know anything about that, what your early childhood was like. That can help us to understand whether this woman is at risk of having bad effects from any traumatic experiences or just generally being at risk of mental health problems. The second thing that we have learned is it is not the obstetric events themselves that predict whether women feel traumatized. It is both the early traumas in her life, but also the amount of support she gets. So if she is well supported by people around her, people close to her, like partner, like husband, if she is well emotionally supported, if she's also well treated with respect, empowered, well supported by professionals around her, even with severe obstetric traumas, she can get through that very healthily. If she is badly supported, if she is emotionally not well cared for, then she is much more likely to suffer the effects of trauma. So again, the events themselves are not such a good predictor. It is how well other human beings treat the mother. And this is a critically important lesson for us as professionals and for families and partners. And we can help encourage families and partners to be supportive, and we can be supportive and sympathetic and understanding and positive, and very importantly, empowering. So where we can, keep mother informed, help her make decisions everywhere where it's possible, so she feels she has some level of control. And this is difficult to do. It is a skillful activity, being a professional at this difficult time.
Kendisine yanıtı için çok teşekkür ediyoruz. Eğer vakti varsa bir soru daha sormak isteriz.
Yes, okay. What time for
İngiltere'de
one more?
Tamamdır. İngiltere'de anne ruh sağlığı için neler yapıldı ve daha neler yapılması planlanıyor? Özellikle sağlık politikaları nasıl değişti?
Okay. Well, in the last 5 years, we've seen a huge increase in investment from the government. So the government 5 years ago put in £365 million into just perinatal mental health as a brand new investment of money. And very often governments say these things but don't deliver. They actually sent the money to our health services. And in those 5 years since that investment, we've seen a huge increase in specialist care. And as I said to you, about 20% of the country, women had access to specialist care. Now 100% of England has access to specialist care as a result of this investment. And now the 5 years for that money is finished, but the government has now invested double the amount. And every year the government is spending £100 million on perinatal mental health care, only on perinatal mental health care. Every year, £100 million to improve services now, not just for specialists, because we now have them in every part of the country, but in maternity services, in health visiting, and in primary care, to try to get that whole of perinatal mental health care dealt with. And they are, even though COVID has hit us very hard in health and economics, they are saying that they are going to continue to invest in these developments and continue forever to spend this money on keeping these services going, because the government say and understand this is really, really important. And we will soon be having another announcement from the government on another increase in spending on child development in the early years. And this will be specifically around services for mother-infant relationship care, even if there isn't a mental health problem. So at the moment we do that, but only where there's a mental health problem. There will also be mother-infant services. So yes, the government in the UK now taking this very seriously, but only because all the professional groups, pediatricians, obstetricians, mental health workers, public health sector, and women themselves, and many, many charity groups throughout the country came together to say, all together, this must be done. This has to be dealt with. And everybody agreed what needed to be done. Step 1, step 2, step 3, and the government then listened. But before that, when we were just speaking our own, health, or pediatricians speaking on their own, they didn't need to do it. They didn't feel the need to do anything. Now they are listening, they are acting. I'm afraid I have to leave you now because I have to go to another meeting, but it has been a huge pleasure to join you, and I wish you really, really well for the rest of this fantastic day, and a great day tomorrow, of course, World Maternal Mental Health Day. So thank you for your warm welcome, and thank you for all the work you're doing, and I look forward to hearing and seeing more of the great things that are happening over there. So good wishes from here in the UK. Thank you.
Peki, teşekkür ediyorum.